How are you? Good morning. There we go. There we go. All right. So I'm so delighted to be here with you all. We're going to be talking primary care, as Q just said. How many of you believe in the power of primary care in your communities? All right. Hoping that we can make that case. How many of you are happy with the state of primary care in your health centers, in your communities right now? Is there anybody? No? I got a couple, all right. And how many believe that we can sort of turn this story around? All right. And how many are you just checking Instagram and email and figuring out what's due to? It's all right, it's okay. I get it, I've been to these things too. I'll try to not be boring. So we have 18 minutes or so together, and we're gonna go down a track on some sort of positive things, some grim stories about primary care, and then hopefully converge around not only why primary care is so obviously important to the community health center movement, but where there's an interplay and an opportunity right now, we think, for the wider primary care community to learn from, to benefit from, and for the CHC community to really align and ally around some core asks that we have together to make for our communities, to payers and policymakers. So we're going to go down that track. All right, so why should we care? If you weren't already convinced about primary care, why should you care? Well, first of all, primary care is one of the only things that we do in the healthcare system that actually is associated with a population level improved life expectancy. So what you see in these graphs is number one, the estimated effect at a county level on the left side, and of the number of days life extended by having 10 more primary care physicians per 100,000. We would have done this, we did this analysis for PCPs, we would have done it for NPs and PAs if the data were there. We'll eventually do it. But the bottom line is this, it doesn't really matter about whether it's an MD or an NP or PA. Primary care availability is associated with higher life expectancy. But, and you see the maps on the right, those are heat maps at the county level. Blue is less, yellow is more. That's primary care on the left map. We're falling in the density of primary care at a county level over the last 10 years, while specialists on the right, and I love specialists, and they're some of my best friends for real, but they're increasing. And I wish I could say, but it's not true, that the availability and density of specialists at the county level is associated with longer life expectancy, but it's not. Only primary care is, and that's through a variety of mechanisms. Now, we love specialists, and some of you are specialists in the room, and we need everybody to keep our communities healthy. But when we talk to our policymaker friends, when we talk to the payers, and they say, well, how can I extend life expectancy in the community? You now have one of the answers. Well, you could pay for more primary care. You could increase the density and the capacity of our clinics to serve the people that we serve in the way that they need serving. Now, this is where the grim stuff starts to play into. This is all data from an annual scorecard that's put together, and what we see is that the number of people who don't have a usual source of primary care is rising. It's now up to almost 30%. That's what Q was alluding to earlier, while the share of the number of PCPs per capita is falling. That's happening at the same time. Now, interestingly, about NPs and PAs, you see that the share of NPs and PAs have been rising until actually last year. There's new data to show that that's plateauing, probably because the working conditions that's making it hard to be a PCP are, of course, the same working conditions that make it hard to be an NP, a PA, an LPN, an RN, or any of the letters that we need to have to make our primary care clinics functional. And the net effect of it is that the number of total clinicians is flat. So we are flat on the number of clinicians per 100,000 to care for populations and communities that have higher needs, that have more complexity. We can do more in healthcare, but we don't have enough people in primary care to do it. Now, there is some hope. this is a slightly complex graph, but look at the yellow line. The yellow line is PCPs, NPs, and PAs in the highest need areas as defined by Social Deprivation Index. And the good news is that there are actually more primary care clinicians in the highest need areas, and that's rising, but that's still not enough. So there's a little hope in this workforce morass. Now, the real problem, at least at the physician level, is that the number of primary care residents going into primary care is just barely increasing. And in fact, as a proportion of all physicians entering primary care, we're now, if you take the light blue bars, which are the more accurate ones, we're now at under 20% of physicians every year who are graduating from residencies are going into primary care. Can we care for the entire nation's primary care needs by having less than 20% of our new fully trained graduates go into primary care? We cannot. In other countries, as Q said, I work a lot with health systems in other countries. In other countries, that share is 50, 60, 70%. They invest in primary care because they know that their communities demand it, that they need it, and that the availability of high-quality primary care done by teams, enabled by data, is the key to better health outcomes. It's a kind of simple open and shut case from a health policy and evidence perspective. It's not from how money flows in politics in the US case. Now here's where it gets a little trickier even more. This is a new analysis, and this on the y-axis, what you're seeing is the share of new primary care physicians going into primary care. On the x-axis is the Medicare GME payments per 100,000 people, and this is, I think, is really important for us to consider, especially those of you who have residents and graduates who are teaching health centers. The dots are states, and the line is a regression, so kind of fit the average curve here. And what it basically shows is that those states that produce more primary care graduates that go into primary care have a smaller proportional share of GME. And those states, like mine, in Massachusetts, New York, et cetera, that get more money for their training programs, which are often in large academic medical centers, are producing more specialists, but getting more money to essentially not produce perhaps the clinicians that we most need right now in the US. That's an opportunity here for us. That's an opportunity to ask hard questions of our payers and our whole graduate medical education system. Is this what we want to be paying for right now? Because we're paying a lot, i.e. like almost $200 billion a year. Now, money matters, and it's not the only thing, but it's really important in this story. And the fact is this. The fact is that primary care only gets 3% to 6% of total healthcare expenditure. For every dollar spent in the US, only 3 to 6 pennies on that dollar are going to primary care. 3 to 6 pennies. For the commercial payers, it's about 6 pennies. For Medicare, it's about 3. How can we pay for the needs of Medicare patients or really anybody when we're paying literally low pennies on the dollar for primary care? And that is sort of tied to this broken production model that we have. Many of you live in the world of RVUs or unit-based billing or fee-for-service-based billing. It's all about productivity, how many visits you can churn, how many things you can bill for. That's not matched by what 21st century primary care looks like. 21st century primary care is about teams of multidisciplinary, highly enabled people working together in between visits and during visits and after visits and reaching out to their communities and doing food as medicine and building in all the social determinants of health work that you're doing. They're not just billing visits. They are putting together a program with their community to enable health. And yet we're paying $100, $120 a visit and sort of hoping and praying that it'll somehow work. So it's really a problem with the distribution of money. And I'm sorry to sort of talk about money, but we need to talk about money if we're going to make anything more than just hopes and prayers and good feelings about primary care. You know, primary care has to be seen not as a nice charity case, not as a nice to have. CHCs are not cute and fun and just, you know, maybe we'll throw you a little money. They're the core part of an effective system that maintains community health. And if that's the case, then you don't give that core part 4 cents on the dollar, right? You don't say that 35% of visits in the country happen in primary care, but 5% of the money goes in there. Just saying, right? I mean, these are just facts. They may be inconvenient, they may be uncomfortable, but these are facts. And the fact of the matter is also that sort of we in primary care, we in the health center movement, look, I trained in health centers, I've worked in and out of them for 20 years. We're generally nice people. We generally come to meetings and are reasonable. And we're totally getting out-sharked by sharks, okay? It's time to stop that nonsense. You don't have to remember any more of my talk, just stop the nonsense. We need to get paid for what we do, not because we're greedy and we want to stuff our pockets. No, because of the communities that we're serving, right? So we got to talk money. And this makes no sense. This makes no sense from like an academic health policy, health planning. This is just crazy. I mean, you got to call it for what it is. This is crazy. You have 384 quality measures that we in primary care are responsible for. You have all of the measures that you know you are and all of your contracts and all of your grants responsible for producing. You're working nights and weekends to make this happen, and you're getting pennies on the dollar and supposed to be responsible for the health of your communities? That's crazy, right? So it's time to change that. Now, you don't have to say, okay, they're like, oh, Asaf, you know, here he goes off again, and, you know, that's... All right, fine. Then let's do some math, because we did the math. And here's the math. If you like papers, you can go read it. You cannot run an advanced primary care practice, i.e. team-based practice that does more than just churn acute care visits, you know, does chronic disease, does proactive outreach, care management, some integrated behavioral health, all the good stuff that we know. Not even the good food as medicine stuff, just the good stuff, the basic good stuff. You cannot run it on what you get paid in fee-for-service. That's not my opinion, that's not my hope, that's a mathematical observation in a microsimulation model run 10,000 times through the Stanford supercomputer by my friend Sanjay Basu, the lead author of this. It's just math. So the next time they try to give you some foolery that is like, oh, well, you know, maybe if you can just churn a couple more visits, you could just somehow make your ends meet and, you know, even deal with the Medicaid cuts, you know, just do some more visits. Give them math, okay? Don't, it's not feelings, it's math. In fact, here's more math. More math says that you actually need to be paid more, and you need to be paid prospectively, meaning like not just on the visits that you did, but on an amount risk-adjusted per patient that you take care of in your panel. If you move that to about 2/3 of your payment, prospective payment, and you move away from fee-for-service and you boost the level a bit, you can actually not lose money in primary care doing those core services. Otherwise, it's nights, weekends, hopes, prayers, and, you know, trying to make those last visits and RVUs count and string together budgets. That's not a recipe for success. That's not a recipe for a healthy primary care system. And we shouldn't ask ourselves why people aren't going into primary care and why people are leaving primary care if they see this math in their head, right? And now we get to add HR1 to this. And you know, you've talked about it yesterday, but look, here you see the proportion of cuts in federal spending and the estimated Medicaid losses of between 8 and 12%. You're looking at 2 to 4 million minimum losses of insurance in folks seen by health centers. You're looking at 7 billion losses in annual losses. You're looking at 34,000 jobs cut. You're supposed to do all that you do with the cuts now playing these fuzzy math games? No, I don't think that's acceptable. I do not think you should accept that. I think we need to activate around something different because of this. This is a National Academy study, and a bunch of people get together and look at all the evidence. Here's 427 pages condensed in 3 bullet points. Primary care, the only part of the healthcare system in which investments in it routinely result in longer lives and more equity. You can go invest in anything else you want. You can go buy some PET scanners, you can go build some hospitals, you can go invest in endocrine clinics, love them, all of them, that's great. But you want to improve life expectancy and improve equity, you invest in primary care, or you won't. Community health centers are the best performing part of the best performing part of the healthcare system. And I'm not just saying that to get a few rounds of applause, and for those of you that are still checking your Instagram because you're bored out of your mind. No, I'm serious. I'm very serious. But I'm also serious about this last point, which is that primary care is weakening at the point when it's needed most. Now, to go deeper on this, why are CHCs the best part of the best part? Because better access, better quality, better value, caring for the people who have some of the most complex medical, social, and psychological needs in our country, and you still do it better. You still do it better, getting the pennies on the dollar. This is incredible. This is like a gem in the US health system that we would be, as a country, absolutely crazy and totally irresponsible to starve of funding at a time when it's needed most. And I'm not saying that as a political statement. I'm saying that as just a factual statement. This makes no sense. This makes no sense. It has to be different. So if you want to improve primary care, remember that 427 pages, here's the latter half of that. You pay for teams to care for people, not just doctors to churn visits. You ensure that everybody has access to high-quality primary care. You train primary care teams, I did say teams, not just doctors, to care for people where they live and work. You design information technology that actually works and doesn't drive you crazy. And you ensure that this happens through accountability mechanisms. Just like they ensure that we have accountability for our outcomes, we need to ensure that there's accountability for these investments to actually happen for us to be able to care for our communities. And then what would we do with that money? Well, we would do more team-based care. We would somehow figure out what we're going to do with these huge numbers of people that are going to lose insurance. So we got to maintain access, and we got to do this with IT systems that actually might help us, i.e. maybe with some ambient dictation and other AI-enabled stuff, and not drive us nuts. We would find more available specialists to actually take our referrals and see them not in 9 months. We would build e-consults, care pathways. We would share risk. We wouldn't just take 384 measures and they get one. We would kind of like make that a little more even. And then we would improve community engagement by increasing our investments in CHWs, making behavioral health integration more real and more available, making effective social health needs referrals be a closed loop in the same way that when we refer someone for a colonoscopy, we know if that happened or not. When we refer them to domestic violence or interpersonal violence resources or food in our community, we know that that referral actually happened through a feedback loop in the system. All of that requires changes in the form of how we get paid, away from fee-for-service, piecemeal visits, in the level at which we get paid, more investment, and in the flow, making sure the money gets to you and your team so that you can do the work and care for your communities. That's the key here. So let me leave you with this, because as you can see, I try to be a nice person, but I also am kind of hard-nosed. I think we need to be audacious. I think we need to demand what not is due to us, but is due to the communities that we serve. So let me end this with the analogy that Q talked about. We were in an Uber a couple months ago, and we were talking about this, and we talked about the need for audacity, and we're like, what could we kind of put together here? So then I thought about the fact that my daughters and I love basketball. One of them plays it, we all watch it. I'll talk to you about our favorite teams later. I love basketball. And those of you that love basketball know about this thing called a triple-double. If you don't know what a triple-double is, let me explain it to you, or you may have heard it from Q yesterday. Triple-double is when you have double digits in 3 of 5 categories in basketball. So points, rebounds, assists, blocks, steals. You may say, why are you talking about this? This is like, well, because a triple-double is a statistically very important thing. It only occurs about once every 20 games. And the team whose player scores the triple-double wins 75% of the time. So a triple-double is a big deal. So here's our triple-double for your sort of, discussion and consideration. We need a triple-double for all of primary care by 2030. We need to double primary care spend from 5% to 10%. Not just the level, but also change the form and the flow. Double it. It can be done. There are states that have done it. Look at Rhode Island. They mandated doubling, and it happened in 5 years, and they got better outcomes. Next, we need to double the number of people who are cared for at community health centers, from 10% to 20%. And before, some of you are like, whoa, 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 whoa. That's assuming you're paid for it and you're given the resources, teams, and available workforce growth to do that work. So 10 to 20%. And then we need to double the proportion of postgraduates choosing primary care from that anemic 20% up to 40%. And that's going to require changes in GME funding and a whole bunch of interprofessional training. So it's a triple-double. It's 5 to 10% on the spend, 10 to 20% on the number of patients cared for at CHCs, and 20 to 40% on the postgraduates. You can't do this alone in the worlds of CHCs. You can't do it alone in the worlds of the medical professions. It has to be a combined effort. So I want you to think about that. And most importantly, I want to appreciate all that you do every day to care for our communities and to be audacious about what you should ask for, and because they deserve more and you can help them get it. Thank you so much.